Hey YouTube, it's Marida from the Nurse Lounge, and today we're going to talk about pain. Pain in the OB patient is what we're talking about today. So if you want to hear what I have to say about pain and how we take care of pain for our patients, then please stay tuned. All right, let's go ahead and jump right on in. We're going to talk about pain today in the OB patient. And as you know, pain, or let me introduce myself for the ones who don't know me. My name is Dr. Marida P. I'm a registered nurse. I've been a nurse for 15 years this year, or is it 16 years? Going on 16 years this year. And I'm an OB/GYN well baby nursery nurse, and I am a nurse educator. And so I'm coming to you with a video on pain and basically what pain is and how we care for pain and for the postpartum patients. Now, I'm going to go through a few different kind of medications that we go through, that we have for our patients, specifically for pain. And then we will be done with this video. All right. So as you all know, pain is what the patient states the pain is, and based off of how they are. We are not supposed to, as nurses, not just registered nurses, but as nurses, judge the patient on their pain. So if they tell you their pain is a 10 out of 10, and then they're on the phone and they're planning a party and they're doing all this other stuff, their pain is documented as a 10 out of 10, and we document accordingly. And based off of that, they can have whatever they can have for pain. Now, for me personally, when I'm administer pain medications, there are certain things I take into account before I give them what they want to have. I do take an account of their pain number. So their pain number, we ask our patients from 0 to 10, what is your pain? 0 being no pain, and 10 being the worst pain you ever had. And let's just say they say their pain is a 9, okay? So the next question I ask is, where is your pain and how does it feel? Their pain, let's just say, is cramping because they just had a baby. And of course, it's in the uterus or in the abdominal area. So we want to think about non-pharmacological methods for pain, okay? So when it comes to something like cramps or things like that, some non-pharmacological methods is, for one, is to empty your bladder. So I tell my patients, empty your bladder. If you empty your bladder every 2 to 3 hours, your bladder does not push up against your uterus. When the bladder pushes up, when it fills up with urine, the bladder does, it pushes your uterus up and it pushes it over, and you kind of cramp some. So we tell them to keep their bladder empty every 2 to 3 hours. That's a non-pharmacological method. Also, you can have what we call heating pads that we put on the abdomen. Now, I'm an old school nurse, but I'm not into old school practices. I do not, and I tell you, don't do this. Do not take a towel and wet it and heat it up in the microwave, wrap it up in a chucks, tape it down, and put it on the patient's abdomen or whatever. That is not legal. I don't care how many nurses you've seen do that. It is not a legal practice. If you burn that patient, when you go to court, what are you going to say? I put it on 5 minutes. Did they tell you and how many kilowatts that is for that microwave? Does that tell you how hot it got? No, you cannot do that. Hospitals have what's called K-pads typically, or they have heating pads that you can kind of twist and break and put on their abdomen like that. But I just advise you, do not do that. You're looking at a liability right there. You're looking to go to court if they complain that you burnt them from that man-made heating pad. So those are non-pharmacological methods for pain. Now, what we're going to use are for that kind of pain. Now, another thing when it comes to the pain, you want to know what kind of pain it is. Why is it important to know? It's important to know because if they are having gas pains, Lortab is not going to fix that. So you need to make sure that you're actually giving medication for the appropriate things. That is why it's very important to ask your patient what your pain is, where is it at, and how does it make you feel. When they start talking about they have pain right through here, and they're a C-section patient especially, that's gas pain. It's a referred gas pain. So basically, due to peristalsis or lack thereof, and due to them being opened up and closed back up from having the surgery, that air has now shot up to the shoulder blade and is looking for a way to go. It's trying to get out. But it can't get out, so it's trying to escape some kind of way. So they have pain up here. We give some methicone for that. Mollicon for that, things like that. That's what we give for those kind of pains. You do not give Lortab for that kind of pain. Now, if they do, because it's not going to fix that. It doesn't fix that. They need to get those air bubbles broke down, and they need to get up and walk. I tell my patients to walk, 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 walk. That's what you need to do, is walk. That's what helps with that kind of pain. Now let's go on to your more known pains, like your headaches and your, let's just say headache. Headache, as you know, is very common in the postpartum period. We need to know why do we have a headache? Check their vital signs. If their blood pressure is up, it could be related to their blood pressure versus truly having just a headache because of tension or stress, or it could be due to the spinal block, epidural area. They need a wet tap, things like that. There's different reasons as to why you have a headache. So when you start giving them medication like Tylenol, and you realize that Tylenol or Motrin, even the Lortab, is not working, you need to further investigate as to why we have this headache. If it's due to their blood pressure being up, you need to contact the physician so that you can see about getting some type of blood pressure medication to bring that blood pressure down. Therefore, that headache typically goes away. But you also will treat them for the headache as well. So you'll treat them for the symptoms of having high blood pressure, which will be your pain medication, such as your Lortabs, your hydrocodones, which is the same thing, your oxycodones, and like I said, your Motrin and Tylenol, things like that. So then the next thing we wanted to think about is our incisional pains from our patients. So we can have the C-section incision, or we can have stitches down there in the perineal area. So we have lacerations and episiotomy down there. And basically a laceration is where your body tears along natural lines, and the episiotomy is where you've been cut. Either way, you've been stitched back up, and of course it's going to hurt. So our non-pharmacological method for that is ice packs, sitz baths, donuts to relieve pressure, especially for hemorrhoids as well. So we want to make sure that we give them those medications, those topicals. Witch hazel helps as well with that area. It soothes and calms that area. So we give them, witch hazel is a medication of sorts, but it's not like a Lortab. And of course, if the pain is bad, we will give them a Lortab and things like that. But I want to kind of give you some ideas about some other issues or other ways to treat pain other than narcotics. So if you have hemorrhoids, of course, we have topicals for that. We have our the water bottle, the peri bottle. I forgot to mention that. The peri bottle is actually a very good non-pharmacological method to use to help either rinse the perineal area off, put some warm water, squirt down there, and it soothes that area very, very well. And if you squirt far enough back, if you have hemorrhoids, it will soothe that area as well. Sitz baths will do the same. And a lot of our patients don't like sitz baths anymore. I think that's maybe trending out. I'm not sure. But we don't really do a lot of sitz baths at our facility. We do the water bottle and like ice packs and things like that for the perineum. Now, your incision, like a C-section incision. For those patients that either come with a morphine, they have morphine, they get Dilaudid. It depends on what their allergies are and what's going on with them. But if they have no allergies, our patients get morphine for the first 24 hours. And they get Motrin around the clock as well. So we schedule their Motrin every 8 hours around the clock, or the physician does actually. We give it around the clock. So they get it automatically, and then they also get the morphine for breakthrough pain. Now we have some physicians at our facility in OB who will give Toradol. I love Toradol. If y'all can get Toradol for your patients, get them some Toradol. Toradol is basically like an IV Motrin. Similar properties. It is not a narcotic. It does not make them drowsy, but it does a phenomenal job with most people's pain. Most people's pain. I find that when I give Toradol to my patients, that they do not complain of, they don't get as much morphine in their postpartum recovery period of time for those C-section patients. So keep in mind that you do want to have, options or have physicians make sure you have options for your patients' pain management treatments. So we do give Lortab or Norco or whatever you want to call it, whatever your facility calls it, which is also hydrocodone. We give that typically every 4 to 6 hours, depending on how the doctor orders it, as needed for pain. We give either 5 or 10 milligrams. Some physicians order a straight 10 for everybody. Some physicians will say if the pain is from 4 to 6, it is a 5 milligram. If it's from 7 to 10, then it's a 10 milligram. Now, and that's the same is true for your Percocets, which is the same thing as oxycodone or Tylox or whatever you want to call it. The one thing I do is, even if the doctor's order, this goes back to my other video on nursing judgment, things like that. If I have a patient who is a pain of a 8, and based on the order it says to give them Norco 10 or Lortab 10, but if their blood pressure is 80/40, they getting the 5 from me. I don't really care what the order says. They're getting the 5 from me because I'm not going to sit there and have to chase blood pressures all the rest of the day. If your blood pressure is already low, why would I want to give you 10 milligrams of Lortab? And then let's say you're working a night shift. Why would I want to give you that knowing you're going to sleep? So I will typically try to give my patients a Motrin and a 5 milligrams of Lortab or Percocet, whatever it happens to be, if I can. There's some patients who have wanted pain medication who I will not give it to because I'm like, oh, your blood pressure is too low for me. I'm not comfortable doing that. I'll give them a Motrin or something else. And then once their blood pressure kind of comes back up again, maybe they needed more volume, more fluids, whatever, they're dehydrated, then I will then give them more if I feel like they're okay to have more. Again, that's a nursing judgment. That's what makes nursing so unique for us, because you can have 3 nurses who have 3 of the same kinds of patients, but all 3 patients are treated differently because of the fact of the nursing judgment mantra, shall I say. I'm not going to do anything that's going to cause me to do extra paperwork. I'm not going to do anything that's going to cause you to fall out on me. I'm not going to do anything that's going to cause you to have me do an incident report that I know of. Now, another thing I won't do when it comes to pain medication, especially narcotics, I will not do giving you narcotic medication to go take a shower. So let's say, for instance, you are, I'm in pain, I have cramps, things like that, and I want to go take a shower because I feel nasty, which that's what they all say. In those situations, I say, you go take your shower first, and once you come out the shower, I immediately give you your narcotic pain medication because I need you to stay in the bed. Why is that? That is because of the fact that when you take those narcotic medications, it causes your vessels to dilate. Once your vessels dilate, then it causes the effect of the medication to take effect much faster and at a more higher rate, shall I say. And when you get in that shower and that warm water just hits your back and has you feeling really good, and you're just like, oh, this feels so great, you stand in there for a while because you feel really, really good. That hot water really feels really good on you, and it's very therapeutic. As a result of that hot water and that narcotic being broke down and going through your system much faster, you end up passing out in the shower. Again, I'm not doing an incident report. We got to do no, you done failed. We got to do that. Now we got to call the physician, and we got to get you back to bed. We got to watch the effects of the medications from that point on, do a write-up, do all this charting, and Dr. Marida P don't have time for all that. So we're not doing that. I will not give narcotics to go get in the shower. I will not give narcotics to leave my floor. I am, yes, one of those nurses who okay, we are not doing this, not today. So what I just recommend you do is be mindful of the effects of your narcotics. Again, for your narcotics, the biggest ones is respiratory depression, which means your respiratory rate will go down. The nervous system, it will just kind of calm itself down, and you will have your heart rate going down. You will have your blood pressure going down. You will sometimes have your O2 sats going down. And like I said, of course, your respiration's going down. So when it comes to something like that, I'm not doing that. You need to be able to take these medications. So let me think of any of the medications that we typically give on an OB floor. IV medications are your Dilaudits, your morphines, like I told you about. We do give tramadol from time to time. It's not IV. We give, what else? That's pretty much it. Unless you have an allergy to something, those are your 2 go-to medications are your Dilaudid and your morphine. We don't really give anything else. We do PCAs, so your patient control anesthesia and analgesia. And we give those, we have that for patients who went under general when they went to have their babies. They will come out with a PCA, or for our GYN surgeries, they have a PCA that's patient controlled. One thing you have to do with that is making sure that no one else is pushing that button but the patient. And I've had to tell patients, family members that time and time again, if they don't push it, you can't push it. And I've had moms. I had a mom of a mom. So my patient was the mom. And then her mother, grandma, was like, well, I don't want my baby to be in pain. Well, she will dictate, when she wants to take her pain medication. If she don't push it, it cannot be pushed. Make sure you educate your patient and their families on the fact that they cannot push the button for them. There is typically a lockout on these anyway, so they won't get overdosed. But the point is, you don't want people pushing medication for your patient. You are the nurse, so govern yourselves accordingly. Any other medications? I want to say for pain specifically, that is pretty much all that we give at our hospital. If there's medications that you give, or let me take that back. You will have your moms who they're on a pain management regimen, shall I say, and they have to take methadone, Suboxone, or Subutex. Those medications are basically a substitute for those types of things so they can wean themselves off of whatever drug that they were addicted to. Some people are addicted to pills such as Lortab and Percocets. Some people are addicted to cocaine, heroin, things like that. Those patients are under a medical treatment plan in which they go to a clinic, basically, and they are getting weaned off of this medication and weaned off of their addiction medication. So whether it be a street drug or whether it be a prescription drug, they're being weaned off of it, and we do give them their Suboxone as a substitute to replace that type of what they were getting. Now, if they are on Suboxone, Subutex, or methadone, they are not supposed to be taking narcotics at the hospital. We have the biggest issue with our physicians still giving some of our patients these narcotics. And even though these patients know better, they feel like, well, the doctor prescribed it to me, the doctor gave it to me, so he or she must know what's best. The patient should know they're not supposed to be taking these medications, and they know that when they sign that contract at the pain clinic, that they're not supposed to take those kind of medications. That is why they're on the Subutex, or why they're on the methadone, or why they're on the Suboxone. That's why they take those medications, because it is a substitute to help wean them off of the narcotic medication. So be mindful, if you have some of these patients that are taking these medications, they will definitely try to push, some of them will try to push for you to give them that narcotic. The best thing you need to do is go to the physician and say, hey, this patient's on Subutex, methadone, or Suboxone, whatever one it happens to be, and you have Lortab ordered. You do realize they're not supposed to get that. And if the doctor says, I'm aware, but we're giving it anyway, well, then that's something different. But I've had physicians who, they didn't even read their order set, because they have a standing order for all kinds of patients. So they have a standing order for C-section patients. They have a standing order for vaginal delivery patients. And so sometimes they don't really think through the person's history to say, oh, let me take that off of their order sheet, real quick, and make sure they don't get that type of thing. So you as the nurse have to manage your patient's care and say, hey, wait a minute. They're already taking Suboxone. Do we really need to be giving them Lortab on top of that? Because it's going to cancel out everything they've been doing. So those, again, are the biggest pain medications we typically give for OB patients. Pain is a big deal. Again, it's what the patient says it is. It is subjective. You give medication whether the patient is a 1 or a 10. I tell my students, when the patient says their pain is a 3, as an example. Now, at our facility, that is our pain goal, a 3. And it's okay to have a pain of 3 or less at our facility. However, I still tell my patients or my students, if the patient says their pain is a 3, their pain is a 3. Did you ask them if they wanted anything? Because they could have Motrin for that. Now, will I give a narcotic for that? Probably not. But they can have a Motrin or a Tylenol for that if we have that ordered for them. So be mindful, like if your patient says their pain is a 3, give them something. If they want it, at least offer it. And that way you can go document patient decline the need for pain medication at this time. We'll continue to monitor or something along those lines. So be mindful that you need to learn how to still address the pain for your patients, even if their pain is minimal. Don't wait till their pain gets to a 5 or 6 or 7 and say, okay, let's go ahead and give you something now. Not unless they said they didn't want it. And that's another thing when it comes to pain. If the patient is a pain of anything really, but if they're 5 or 6 where you would normally be intervening and giving some type of medication and they say they don't want it, put in the documentation, patient denies the need for medication at this time. Because in 5 minutes, they will come back and tell the next nurse that they needed some pain medication. Matter of fact, I had that happen to me on my last shift. I had medicated the patient at 12:20. I remember the time. It was 12:20. I gave her a Motrin 800 for her pain. So the next nurse comes in just 10 minutes later and says, I need my pain medication. Well, I happened to walk in right behind her to do the discharge teaching, and the nurse tells me the patient wants some pain medication. And I said, I just gave her some 10 minutes ago. Mind you, the patient's just sitting right there. I just gave you some pain medication 10 minutes ago. And she said, well, that's not working. I said, give it 30 minutes to work. You won't get it from me before 30 minutes. You have to, she said, well, my pain is a 3. No, I'm not giving you anything stronger for a pain of a 3 when you just had Motrin 10 minutes ago that you have not let take effect quite yet. In 30 minutes, when I come back and reassess your pain, if you still need something stronger, then I'd be happy to oblige. But until then, you're going to have to wait. The other nurse was like, oh my gosh, why didn't you just give her some medication? You go give it then. She didn't need it. Let the medication do what it's supposed to do first. I'm not one to push pain pills on nobody. I don't push pain pills on nobody because I need you to be as alert and as functional as you possibly can be. Also, in OB, there is no such thing as pain-free. I don't care which way the baby came out. It came out your vagina or it came out through your abdomen. You're going to be in pain at some point in time until this healing process is done. So yes, you may have pain relief in terms of not having pain for the moment, but that pain is going to come back until that healing process is completely done. So I do not believe in being pain-free. What I do believe in is having the pain at the lowest possible rate that we can get it so that you can function, so that the patient can function and manage and care for themselves as well as their baby. So what videos do you want me to do something on? Comment those videos below. Pain is always a big one, a big topic for our patients. So I thought I'd do a separate video on pain for you all so that you are pain in terms of their sources and how we treat them. I will say this, epidural pain. So that pain back there is very normal to have. And besides a Motrin or something like that, that's really all they need, Motrin and or a narcotic from time to time. Narcotics, side effects. Make sure you talk about the side effects of your narcotics to your patients. You should actually be teaching side effects to medications every single time that you pass a medication. So if you are passing even a Colace as an example, you should be talking to your patient about the side effects of the Colace and telling them when to let you know so you don't have to take, or so they don't take it anymore. So as an example, Colace is a stool softener. It's not for pain. A stool softener does not make you go to the bathroom. It does not make you have a bowel movement. What a stool softener does is allow the intestines to keep the water to make the stool soft. So when it does that and it makes the stool soft, it makes it easier to pass for our patients. Now, I do tell my patients once you get diarrhea, it's done over and beyond its job. You need to stop taking the stool softeners at that point in time. So again, educate your patients about the medications they're taking, what the side effects are of those medications, and when to contact you for further assistance. When it comes to your narcotics, again, we talked about respiratory depression, heart rate, O2 sats, blood pressure tends to go down. It makes them drowsy. If something makes them drowsy, it can also make you unsteady when you walk. So therefore, they could easily fall. It can make you disoriented for a slight period of time. Think about this. Have you ever been to a hotel room? You going out of town, you going on vacation, you go to a hotel, and you wake up at 2 o'clock in the morning because you have to use the restroom. And you wake up and you're kind of like, where am I at? You for that brief moment, you're kind of disoriented. And you may step off and you could fall or something like that. The same thing happens with our patients in the hospital. They know they're in the hospital, but at the same time, they're like, where am I at for that brief millisecond or whatever? Be mindful of those types of things so that you can basically talk about, you know, what to do and when to take these medications. When it comes to OB and they're taking narcotics, I tell the moms to make sure they feed their babies and put their babies back on the crib, because when they do go to sleep, they tend to sleep, I would say, relatively well. And some moms tend to fall asleep with their babies in their hands and their arms. And as a result, sometimes those babies fall and can get injured like that. So we want them to feed their babies, change their babies, feed their babies, swallow their babies, and put their babies back in the crib when they take those narcotics. And when it comes to patient teaching going home, we tell them the same principles still apply. I tell them if they have to take narcotics, take it when they are taking it at night. Do not drive with these medications in your system in terms of like just took a narcotic and think you're going to go drive somewhere. It's probably not going to happen very, very well. So this is it. This is it for real this time, for real. So anyway, if you have anything you want me to do a video on, please comment that below or follow me on IG. You will see my handle here on the banner and in the comment section description box down below. I am a registered nurse and I've been a nurse for, again, 16 years, almost 16 years. And I would like for you to follow me on my social media platform, which is IG. Follow me over there. That's where you find out what's going on the rest of my life. I just finished my doctoral journey and I am Dr. Marida P now. So anyway, until the next time, you all take care. Bye-bye.